Voilà, mesdames et messieurs, bonjour. J'ai le plaisir et le privilège de vous accueillir pour cette conférence donnée par Antonio Pascual-Leone, conférence qui est liée d'abord aux relations d'amitié, aux relations scientifiques que nous avons avec lui, puisqu'il collabore à plusieurs projets de recherche que nous conduisons ici et aussi à l'Institut de psychologie, et puis surtout que Antonio est professeur invité de la faculté de biologie et médecine. Vous savez que ce sont des titres qu'on donne pour valoriser certaines collaborations scientifiques avec des collègues de l'étranger et qui permet dans le fond de leur rendre honneur et de favoriser les liens qu'on peut avoir avec eux. Il est psychologue, chercheur et clinicien. Et dans le domaine de la psychothérapie, on voit souvent des collègues qui ont ces deux casquettes, de pratiquer eux-mêmes la psychothérapie, ce qu'Antonio fait notamment dans le modèle de la psychothérapie centrée sur les émotions, pour les individus, pour les personnes seules et pour les couples. Et puis en même temps, c'est un chercheur de pointe dans le domaine de l'étude des émotions, ce dont il va nous parler aujourd'hui, avec cette possibilité de faire le va-et-vient entre la pratique clinique et les modèles de recherche, qui dans notre domaine, comme dans d'autres, vous le savez, n'est pas toujours très facile et très simple. Le clinicien ayant d'abord une adhérence et une croyance dans sa théorie clinique, et puis le chercheur se devant plutôt de respecter ses exigences méthodologiques qui sont en général d'un autre ordre de rigueur scientifique. Voilà. Je vais passer la parole à Uli qui va aussi dire quelques mots. Uli qui est dans le fond celui à qui on doit cette collaboration privilégiée avec Antonio. Uli.
Bonjour à tous. Donc, c'est bien sûr un grand honneur d'accueillir aujourd'hui et de présenter Antonio Pascual-Leone comme professeur invité de l'Université de Lausanne. Et puis, je me permets de rappeler quelques liens que l'Université de Lausanne, le département de psychiatrie, a avec le professeur Pascual-Leone. Depuis 2012, il a conduit des ateliers de recherche et de clinique ici. Et j'ai aussi, d'un point de vue personnel, eu le plaisir d'accepter ou de bénéficier d'une collaboration scientifique depuis ce moment-là, d'abord comme professeur invité en 2013-2014 à l'Université de Windsor au Canada, et ensuite comme adjunct faculty dans cette université également. En 2015, le professeur Pascual-Leone a participé à une étude sur les données de psychothérapie psychodynamique brève qui ont été récoltées ici à Lausanne au sein de l'Institut universitaire de psychothérapie. En 2016, le professeur Pascual-Leone a collaboré avec le professeur Herpertz et moi-même à une critique méthodologique, je dirais importante, des designs de recherche qui utilisent des procédures expérimentales pour mesurer les émotions en psychothérapie. Et puis en 2016 également, Antonio a participé avec des collègues à Lausanne, à Berne et à Bochum à une recherche sur le changement émotionnel chez les personnes avec un trouble de la personnalité narcissique et histrionique. Ce travail, publié dans le Journal of Personality Disorders, a reçu un prix prestigieux par la Société pour la recherche dans le domaine des troubles de la personnalité. En 2016, également, Antonio Pascual-Leone a participé à une recherche conduite à Lausanne, ici, au sujet du changement émotionnel dans le traitement comportemental dialectique, également une recherche menée au département de psychiatrie. Et finalement, la collaboration se poursuit, il y aura encore plein d'autres choses à mentionner. Et le professeur Pascual-Leone est expert de plusieurs mémoires ou collabore étroitement sur l'évaluation de l'automépris en psychothérapie qui s'est avéré un processus particulièrement néfaste pour le changement en psychothérapie. Et finalement, pour un fonds national que nous avons obtenu récemment, le professeur Pascual-Leone est un collaborateur formel. Il s'agit d'étudier les mécanismes de changement d'un point de vue neurocomportemental chez les troubles de la personnalité. Donc, c'est un grand plaisir d'entendre Antonio.
Wow, merci beaucoup. Je voudrais bien remercier pour cette présentation très généreuse et pour la longue collaboration et amitié avec Uli Kremer. Et extender mon gratitude à Jean-Nicolas Desplan pour avoir présenté mon dossier de candidature pour le titre de professeurs de recherche invités. Je voudrais bien aussi remercier la faculté de biologie et médecine et aussi le département de psychiatrie pour avoir extendu cette opportunité de présenter avant vous. Et maintenant, je crois que j'arrive très à la borde de mon quota de fautes en français, donc quotidienne. Donc j'arrête et je passe à l'anglais pour la présentation substantive. Mais peut-être on peut avoir, s'il y a des temps de questions en français après, mais on verra. OK. Merci beaucoup. So what I would like to do is talk to you today about a line of research, excuse me, about changing emotion with emotion. The subtitle of my talk is How Do People Work Through Emotional Difficulties? I think, you can think of emotional processing as a task. And so this is an idea I'm introducing here, right? And others have as well, Les Greenberg. And the idea that, often we talk about emotional processing, clients talk about it, therapists love to talk about emotional processing. And in everyday life, we talk about working through emotion, but as if that were self-explanatory. But it's actually, I would say, more of a label for a problem than an explanation of what actually is emotional processing. And we could be talking about things that clients do in session, but we're also talking about the ways people are moving through personal difficulties in everyday life, right? You have a heartbreak or lose an opportunity in life, and you have to work through it in some sort of way. So that's this becomes a task. You can think of it as an implicit emotional task. I shouldn't skip over the fact. What I'm going to present, so that's just by way of introducing the topic. What I am going to present is a program of research that I started and that many people have since contributed to. A lot of the work done here at in the Department of Psychiatry here at the University of Lausanne. So I'll be presenting other people's work as well as my own. And this idea that emotional processing, I guess I'd start off by saying, following the line of work of Les Greenberg and some others, I think it's useful to think of emotional processing not as a single entity, but as there's several kinds of emotional processing, ways people change how they feel, right? I mean, that becomes the puzzle. How do you change how you feel? And, one can think the most obvious is going to be inhibiting emotion, fine. But you can also think of engagement and awareness, maybe expressive arousal. Here we have inhibition or downregulating emotion. There's reflecting on emotional experience, putting it in some sort of narrative. And finally, this idea of sequences of emotion. So this may be newer to you as an idea. But the idea here is that when I started by talking about emotion changing emotion, which is a turn of phrase introduced by Les Greenberg, but in some sense that's making a reference to, in cognitive behavioral therapy, the idea is essentially that your thoughts can change your feelings, right? That thinking changes emotion. This is a kind of a broad brush I'm using. I'm introducing this other idea, which comes from championed by emotion-focused therapy, that actually sequences that an emotion can change a subsequent emotion. There's something about the series of emotions that actually might be important. So that's what I'm going to talk about and focus on today. And we've studied this. So we've studied sort of sequences of emotional processing. And the first part of my talk will be to sort of describe a model of how people work through sequences of emotion. To illustrate that, I'll give some client examples and so on and so forth. And the second part of my talk will be talking about the research that we have to support this idea. Okay? What we're really talking about here, by the way, is emotional processing and a specific kind of emotional processing as a mechanism I would say that these are probably all mechanisms of emotional change in therapy. There are non-emotional mechanisms of change, of course, but I think this is I'm going to mount an argument today that this is actually a mechanism of change. To start this off, I mean, how do you sort of start with this? Well, I was sort of saying you can think about the types of problems people have, the working through of some difficult experience as perhaps, I think when you know, we've all had difficult experiences to work through, let alone clients or patients you may have worked with. And it, you know, emotion often seems like an arbitrary or kind of semi-random sort of, right? There's a flux, an ebb and a flow, and there isn't a pattern. But I'm arguing that there actually is a pattern here. When it's productive, when it's not productive, we don't find those patterns. And the way we started studying this is just collecting examples of clients who are distressed. So the idea here is this, you can think of resolving distress as this kind of a meta task. You know, it's very simple. This is called a task analysis. It's a qualitative, quantitative hybrid method. I won't get into the method. But basically, the big punchline is you start with cases of distress, and then you sort them into what's more resolved and less resolved. And the puzzle is this. What do these people have? What are they doing, either in terms of elements or in sequences? And what do they have in common? What do these people have in common? And what are they doing that's different from these people? Right? Because obviously there's going to be a certain number of unproductive processes that are false starts or detours. So what do they have that's different from these people? And essentially one works through looking at cases and creating these empirical models based on case studies, right? A series of case studies in this sort of systematic way. And one ends up with a model, which later, after I explain the model, will be subjected to quantitative analysis. So we have a model, but there's also a measure. So this ends up being the model, and I'll go through it really quickly, and then I'll describe each of the states, okay? But basically, the idea is people begin in sort of a global, overwhelmed sense of distress. If they differentiate that, it'll either be kind of a fear or shame, some sort of maladaptive emotion, maybe rage. There are elements to that experience, and then we get to more productive emotional experiences, which will be assertive anger, self-compassion, an experience of grief, and finally, some sort of resolution, which is going to look like a sense of acceptance or with a sense of agency, right? It's not resignation. So this is kind of the series that we're talking about. And I'm suggesting, here's a hypothesis, right? That this is actually a developmental process, that emotional transformation is, if you think of emotional development, and one thinks of children, obviously there's emotional development in children. But by and large, the development that children have with respect to emotion and their experience and their ability to work through emotion is due to maturational factors, right? They have more engine power, their brains get bigger, they have more computing power, so to speak, and they're able to work through things. If we think about adult emotional development, which I think is part of what happens in psychotherapy, then we're talking about a developmental task that's effortful and people actually work through. If you're thinking about therapy, this would be an overarching task within which there would be all sorts of technical interventions, right? If you're doing chair work in emotion-focused therapy, focusing, narrative, homework, whatever therapy you're doing. There are lots of things we do in therapy, right? Those tasks would all be in the service of some sort of emotional development. And then that would be nested within kind of a macro task, which in therapy might be the therapeutic relationship. Outside of therapy will be kind of the socio-historical context, okay? So this is what we're talking about. This is something that could unfold within a session, but more likely will unfold across a series of sessions, okay? I'm going to describe this model a little bit. I think it's useful just to sort of start the idea that there are several phases, right? So you can actually group emotions as being secondary emotions. These are symptomatic emotions, general distress, rejecting anger, then sort of fear, shame. Some people have talked about primary maladaptive emotions as sort of the core difficulty related to psychopathologies, which can be of various kinds. And finally, a phase of more productive emotions. You know, productive doesn't mean it's good. I should say, doesn't mean it feels good, right? These aren't happy emotions. These are productive experiences. So, grief can be a very painful experience, and yet it could be a healing experience. So, as we kind of go through these, I'll sort of try to, as I said in the first part of the talk, which we're doing now, sketch out the different, how do we define these sort of things? And as I mentioned, there's a model, which you're seeing in front of you, but there's also a measure, criteria where we can watch a videotape and observe and code independently in a reliable fashion whether people are in this state or that state. Usually the coding is done minute by minute. Okay. So this idea of secondary sadness or global distress, I mean, what we're talking about is, the defining feature is people have high arousal but very low meaningfulness. They're very upset, but they don't know what they're upset about. So this is often symptomatic distress. It could look like sadness, could look like anxiety or hopelessness, but it's not specific, right? And there's very high arousal. Some quick examples. Therapist says, "How are you feeling today?" "I feel terrible today." And there's kind of an emotional crack in her voice. "Are you?" "Yeah, I'm a mess." "Tell me, what's going on?" This is kind of the key, right? Because the client turns out she can't really explain what's going on. She shrugs. "I burst into tears 10 times a day. I don't know. I feel depressed. I have no energy." So she starts to sniffle. "I'm finding it just really hard to get on with normal things, and I feel really tired. I'm just not myself at all." "So what's going on for you?" the therapist presses. "I'm not sure. I mean, just irritating normal things happen, and I feel all alone and stuff like that." And stuff like that. It's the vagueness which is kind of idiopathic here. In another example, clients is asked to do an empty chair task, which is, many of these examples that I'll be showing you are from emotion-focused therapy. But the studies will be on emotion-focused therapy or other treatments. In any case, the client is sort of asked here to engage in kind of imagining speaking to another person. She starts, I feel like crying, and that comes in my upper throat and my eyes, and I don't, can you tell her that? The imaginal task. Can you say to that, "Mom, I just have to look at you, and I feel like I want to cry." She sort of orients and she tries it. "Mom, I just have to imagine you in that chair, and I feel like crying." And she sobs suddenly. "Yeah, it's like I feel so sad." "It's okay, it's all right." "So there's just so much sadness." "Yep, there's a lot." "Can you tell her what the sadness is about?" Looking for specificity. "Are there any words that come with the sadness, or is it just sadness?" That's a tough one. "I just feel sad." "Yeah, I just feel sad." Kind of wordless sadness. I mean, the therapist is struggling here. "Kind of hopeless," says the client, right? So there's something there. This is real emotion, right? But the specificity is really missing, right? Another way clients go is to rejecting anger, what I'm going to call rejecting anger. You can think of this as sort of secondary anger, sometimes referred to as rage. And I think one contribution of this model is actually, as we'll see, is distinguishing between concretely what is more productive versus less productive examples of anger, more productive versus less productive examples of sadness. So this kind of anger is a distancing, blaming, destroying. It's not about what you need, it's about what you don't need, right? So we have clients, examples where client sort of says, "He's repulsive, I'd just like to punch him out." Or another, same client later on, "I'm disgusted, I just want to get rid of him." He's referring to an abusive parent. Another client, I hate him for what he did to me. I'm really pissed off, right? So there's this kind of this pushing away, which actually is could be a healthy stepping stone on the way to assertion, and yet it's not yet clear what people are actually fighting for, other than they're fighting not to have some experience. As we move to more specificity, we enter these kind of more maladaptive emotions, fear and shame. I'm not suggesting that fear and shame are the same. They are very different experiences. but they're functionally equivalent in the sense that they both, for the purposes of a model, right? They both involve collapsing and withdrawing with very little sense of direction. You can think of this as kind of this deep, enduring pain, right? In a more narrative frame, Lynn Angus has talked about the experience of these emotions as the same old story, right? So it's that familiar pain that people will go to. It's not the symptoms, it's I'm always abandoned, or I'm always alone, or I'm always feeling inadequate, right? So this is that core sense. And here, I mean, there will be arousal, but it's not going to be so overwhelming that people, as it would be up here, right? People are able to make some meaning, and it's usually along the lines of feeling defective or unlovable or somehow unable to survive, which are these negative core evaluations. You can think of core dysfunctional beliefs or things like that. In an example, the client says, he's asked to give an example in speaking to himself. And he says, I can't give an example. It's just, he's speaking to himself. Everything you say is just a bit off, off of how other people see things or talk about things. And he covers his eyes and he suddenly begins to sob. It just really hurts. It hurts to say that. What's the sadness? I mean, therapist is fishing here, looking for the right label. Can you say the words? There's quite a long pause, and he says, she tries to help. Is it just a feeling of inadequacy? That's actually a little closer. A feeling of inadequacy that gets pulled. He says, well, I just have to monitor everything I say, even while I'm saying it, because I know or I feel that everything I say is just a little bit off, just doesn't, people will do a double take when I speak or disregard me as a nutcase. The contrast to this kind of self-criticism or condition of worth is this idea that there is kind of an unmet existential need, and those will kind of be the core of what's pushed forward in these kind of more adaptive emotions. So moving forward, I'm just watching my time as well. These primary adaptive emotions, you can think of assertive anger as being one of them, right? So this is a healthy assertive anger where the person has a very clear sense of what they're fighting for. There's arousal that kind of gets them to fight for what they need to defend themselves with a very clear sense of what the unmet need is or what the injustice is, right? I won't accept this, says one client. I have value. I have been mistreated. Or another client whose parent was very intrusive and invasive. She says, I'm different from you. I exist. I deserve, and so forth, to have my own sense, right? And from a study done here, a case studied here in the Department of Psychiatry, it's my right to play here. This is my space, says the client. I have the right to play here, and right now, I need you to respect that. So, there's some similarity. It's still anger, right? Defending a boundary, but there's a very clear sense of what is the existential need that is unmet and is being championed. The other side to that is a grief, of course, right? This idea that there are losses, okay? So this is not global sadness where, right, we remember from before, I'm so sad, but I don't know why, or I don't know what it's about. Here, this person really knows what it's about, right? This is the same client who was talking about feeling disregarded. He says, in many ways, I never had a family. If it weren't for, extended family, it wouldn't have been much. Yeah, You're missing that in your life. Well, I'm missing that particular type of love, I guess. And he starts to cry, the love that only a parent could give a child. So there's nothing that can replace that. There's nothing that can substitute that. Well, not from my experience. I had aunts and uncles and that who I know loved me, but it was never the same. And of course, that's true, right? There is a loss here, and he's acknowledging this very specific loss. People are shifting between emotions, right? The shift from grief to sadness, and then, from sadness and grief to anger, assertive anger, and then back again is something that reoccurs, right? And it has to do with this dialectic in some sense. One client actually acknowledges and says in a session, "This is where I start to get angry. I feel the anger in the place where the sadness was." And she actually moves. And that's what this whole model is about, the sequences of motion, people shifting between states. Self-compassion is going to be another, again, it's not the same as assertive anger, it's functionally equivalent, right? Here people are asserting, or affirming is a better word in this case, an existential need, not necessarily fighting for it. I don't think everybody has to go through anger, but there are other ways of affirming your need, maybe giving oneself what one needs. So this could be self-compassion or attributed nurturing, where you imagine somebody attending to your needs. Sometimes it's just recalling the available resources and people kind of being mindful of how their needs are being met now, right? And that activates a different scheme, really. This client is role-playing another person and imagining, saying to herself, "You deserve to be treated well. You have your husband who loves you, you have your sisters." And I remember from the video, she said, your children brought you flowers the other day, and so on and so forth, right? Another client says to herself, "I love you, it's going to be all right." So these are these quick examples. You know, when people work through this, there is kind of an acceptance and agency. It feels like I can breathe again, says the client. It looks like that ball inside my chest is kind of loosened. Okay, so take a deep breath and see if you can breathe into that ball in your chest, says the therapist. Just notice if anything comes up that you would want to say to your dad, or is there anything you want to say goodbye to that will never be again? I guess I'm going to try to say goodbye to that part of me, that child that was hurt and was defenseless. I'm not going to ignore her. She'll always be there, and if she wants to say something, I'm going to listen. I'm not going to be a child anymore. Right. I'm an adult now. I have control over my own destiny. I'm not... Oh, interrupts the therapist. It's like goodbye to being defensive, goodbye to that. No, right, yes, that's correct. Goodbye to that. Goodbye to being a victim. So this is the model, right? And I think it's important to sketch out qualitatively these different kinds of emotion, because what we'll find is sadness. Experiencing sadness predicts outcome. Great. But the question is, what kind of sadness, right? That specificity is going to be quite important for understanding how emotion changes emotion, how emotion predicts outcome, and also for the clinical interventions. What are we actually going to get therapists to do, or what should therapists be looking for in a session? So the first part is this idea of, I show you a model and I describe it, and hopefully you kind of nod and say, "Oh, yeah, I kind of recognize pieces of that," which I think is really the contribution of qualitative research, is people recognize it, right? It's like, "Oh, yeah, I thought that was true," something like that. But then one needs to ask, well, has it been studied? Does it actually relate to outcome? And it has, right? It's actually been studied in a number of treatment approaches. So the examples I gave were from emotion-focused therapy, but here we have quite a number of treatment approaches. And my point here is they're quite different. Humanistic approaches, one study, psychodynamic treatments, behavioral treatments, and even other interventions. The reason why this is important is to show a range of studies, for sure. But, if you have sequences of emotion, and if the argument is this is a change process that occurs, that is a developmental process fundamentally, and would occur irrespective of the approach to therapy, an easy criticism would be, well, if it only happens in this approach to therapy, then it would be an artifact of the therapeutic intervention, right? The therapist is pulling for this emotion, and then the next intervention pulling for some other emotion, and you kind of pull the client through a model. Whether you are aware of that model implicitly or explicitly wouldn't matter. It would be an artifact of interventions. So the punchline here, the fact that it occurs, or that there's supporting research from many different approaches, is speaking to this idea that actually this may be a pan-theoretical model or construct. Most of the research, admittedly, is from a humanistic perspective. That's not supposed to happen. largely in emotion-focused therapy, but also in some quite different approaches. Finally, I mean, you could also wonder, well, if, say, you were mostly studying depression or mostly studying, you know, the idea of stages of grief, which actually is a predecessor of quite an old predecessor, right? This idea that somehow people work through some stages, which has been very, not really a falsifiable model, whereas this one is, I think, is specific to grief. Oh, I'm sorry, K, yeah. K indicates that, whoops, here we go again, is the number of studies. So in these sort of, I'm saying this is the, oops, doing it again, is the number of, N is the, these are different studies, and this is the total number of of clients across these studies, whereas K is the number of studies. I'm sorry, these are the examples, right? So that's true in here as well. This would be 16 studies on emotion-focused therapy, 2 studies on psychodynamic. Yeah, okay. They're non-redundant, so if there's the same studies on 2 different, on the same population, it shows the K is different, but it doesn't change the N, right, the sample size. You know, getting back to this idea, I mean, you could also think, well, maybe there's sequences, but it would be related to particular clinical presentations, particular problems. And what we have here is I'm showing depression, complex trauma, anxiety disorders. I mean, now there's a treatment manual that uses this model as a centerpiece for how to treat anxiety disorders in EFT. And personality disorders. So this is quite a wide range of treatment populations with supporting evidence. You know, there's always more research to do. There's about 24, 25 studies and a total sample size of about 310 clinical cases. So, which is, you know, each study is relatively small because process research is like that. So what's mostly speaks to depression, complex trauma, and personality disorders. This is an overview of the research. So I have done a review paper that sort of talks about the research being done. And I'm certainly not going to go through every little piece, but what I'm wanting to show you is the different kinds of levels of research that have been studied. If you want to study mechanisms of change, it requires many different levels of evidence, right? First of all, for example, you would have to show that emotion does unfold in these particular sequences. Those are kind of all the red lines, that emotion predicts emotion. Mm-hmm. That there are conditional relationships. And secondly, you'd expect those kind of links to predict a good session, that you have a good session, right? That somehow this session where that happened is particularly productive. That would be the short outcome, the small outcome. And then the distal, or kind of the final outcome, you would need to show that seeing these emotional experiences, so those are the green arrows, right, predicting session outcomes. And then the blue arrows are the things over here are actually predicting final treatment outcome or symptom change. It's not that you had a very productive session, but also that symptoms actually change by the end of treatment, and you can predict that based on observation what happened within a single session. So I'll go through different parts of this, but not exhaustively, but to illustrate a little bit. The idea here is that specific sequential pathways have indeed been tested and supported from across different populations. So this is kind of a flash of you know, these sort of findings here are ordered sequences, right? Nested sequences, that if this happened before this, which happened before these, which happened before this, then that predicted outcome. So here are the arrows between boxes, but there's also these kind of, when these happen in this series, it predicted outcome. I'm referring to outcome now, those session outcomes. You know, this is kind of the main idea, that when one looks at good outcomes, this is from a specific study, but I think it represents. When one looks at good outcomes versus poor outcomes, I'm talking about session outcomes, productive sessions, that you actually find a very similar range with respect to some emotions, but the ones that stand out are assertive anger, self-soothing or self-compassion and this idea of grief, that those are unique to good outcomes. Another way of looking at it is if we go to this model here, these things happen in good sessions and in poor sessions. But these things only happen in the good sessions. So that's what we're talking about. The second piece we're talking about, these things happen before those things. So you can't really jump to it, right? I mean, it'd be easy to say, oh, great, let's just do this. That would be nice. The puzzle is you can't, because these are, in some sense, the entry points. The only way out is through, is one way of thinking about that. So as we move along, you'll recognize this from earlier, and now I'm referring to these green lines and blue lines, just sort of summarizing. The model also relates to outcome, right? There are, I'm trying to represent the scope, but also the limitations to the number of studies. There are 7 session outcome studies, sort of showing that the process we've just talked about here predicts session outcome. And there are 5 treatment outcome studies, right? So those treatment outcome studies, are showing large process to final outcomes. The effect sizes are quite large. We're talking about effect sizes, a D of 1.2 ranging to 0.78. I mean, this is quite large. We're talking about a process, the power of a particular observed process to predict symptom change. Also, another way of looking at it is explaining as low as 15, as high as 19% of final symptom outcomes. This is a big chunk, right? If you think of the sort of things that predict outcome, obviously the alliance predicts outcome, the depth of experiencing. I mean, I'm interested in what happens in the session that predicts outcome, okay? What are we doing in the session? What can be observed in session? And these are quite substantial compared to the other things we know, the few things we know, that what happens in session as a predictor of outcome. One study even showed that increases. So, one thing is having these emotional experiences predicts outcome. Another issue is if you actually increase the amount of this experience, the amount of this emotion, target emotions, right, specific ones, that it, from early to late in treatment, it actually doubled the odds of successful outcome. That's, I think, quite important, right? If I were a therapist, that means I double the chances of this being a good outcome if I can facilitate some of these key emotions. It's going to be tricky because those key emotions will have to be preceded by other more distressing, less productive emotions and so on and so forth. This is not going to be easy, but it kind of creates a clear clinical implication. The other thing I'd point out, we're not talking about, I'll just jump to what we are talking about. This idea that emotion is a thin slice. I want to introduce that. This is kind of a turn of phrase that Malcolm Gladwell and some other people have talked about, right? Emotion events is a thin slice of process. We're coding emotion minute by minute. That's a very thin slice, right? And for example, a study done here at the Department of Psychiatry on psychodynamic therapy, a single minute, 1 minute of grief, a single minute of observation of this particular kind of emotion defined this particular way was a robust predictor of reduced depression over 2 months later, post-treatment. We're talking about 1 minute of observation predicting symptom change 2 months later. That's a thin slice, right? I mean, what do I mean by thin slice? I mean, I think there's something quite penetrating about somebody having a certain, it's not an arbitrary experience, that this runs quite deep, cutting to the core of what might actually be some of the change processes in psychotherapy. Again, great, emotion predicts outcome, but what kind of emotion? So defining the specific construct is pretty important, right? It's grief. And what kind of grief? You go to the article, you look at the model, and I'm saying this kind of sadness. It's not just crying in session that predicts outcome. It's articulating the unmet need and so on and so forth. I jumped to a different study, right? So we're kind of looking at several levels of analysis. Sudden gains is something that happens in therapy. This is just right? We know this. Although one might think of emotional change or treatment change as being gradual, and sometimes it is, right? People gradually in therapy becoming less depressed. It actually, in about 40% of all of therapy, if one kind of looks at studies of all kinds, about 40% of cases experience sudden gains. What is that? Well, sudden gain is this. If we have this is not necessarily the first session or the second session in treatment. I'm just giving you 4 sessions. Right? Might be in the middle, beginning or middle of therapy. People are plugging along, and yeah, there's these kind of subtle increases. This is the Beck Depression Inventory. So down is good, right? Down is fewer symptoms. And what we have is, at some point, there's a disjunction. There's a dramatic drop. This is called the sudden gain, right? Loss of symptoms, a gain, an improvement. So there's a sudden improvement. It's not a gradual, it's a sudden drop in symptoms. That happens in about 40% of psychotherapy cases, irrespective of treatment approach. Happens between 2 sessions, right? That's how we're defining it. Okay, this is a research opportunity, right? The puzzle, the question, you have a sudden gain here, and if you're interested in studying how therapy works, the question becomes, what happened in this session? What happened? What happened here that was immediately followed by this improvement, symptom improvement? There has not been very consistent research on finding what's happening in this session. And there are a number of reasons for that. I think measuring the right processes is a big issue. But one study has been successful. So if this is, here we're looking at symptoms, and so down is a drop in symptoms. Another way of doing this, by the way, is you're going to be looking at what happens in this session, and how is it different from this session, right? That would kind of be the control session, to kind of create a comparison across time. If we look at these kind of motions at the bottom of the model, do primary adaptive emotions play a role in facilitating sudden gain onset or sudden gain? Turns out assertive anger, self-compassion, and grief actually do. That control session, after that, there's suddenly a lot more of these emotions in this session. And after that, a sudden gain. Okay? So this speaks to the idea that perhaps, at least in this approach to therapy, experiencing certain kind of emotions are leading to these dramatic improvements when clients have them. You could, of course, say, well, maybe it's just emotion in general. That would be a good critique. So it's important to look at what I'm saying are less productive emotions. The interesting thing is here you have sadness, here you have anger, but when we go here, you have sadness, again you have anger, right? Grouping them together, however, you don't find any change from the control session to the critical. The sudden gain happens here, and it seems unrelated to what's happening inside the session. It's certain kinds of emotion. So I've given you an example of relating it to outcome. One could ask, is this research that matters, right? I think there's a lot of, to therapists. So it's very important to me to use a unit of analysis, for example, coding videos minute by minute, because therapists are in attendance minute by minute, right? If a researcher can watch a video and see a client go through an emotion for a minute, another emotion for 2 minutes, and you can watch it in real time, then a therapist could conceivably watch this happening, right? So that becomes the question, is this something that therapists can see happening in front of them? Now we get to some fancy math, right? Because if you have evidence that this is a model and that it actually occurs in a particular order, those red lines in the overview slide, you could actually number these states to create an ordinal scale. It's like I flatten it. You with me? So now we're going to end up with a 9-point scale that is a qualitative continuum, right? These are ordered, qualitatively different emotional states that are ordered in terms of the, let's call it, degree of transformation, okay? So to make it simple, we have a 9-point state. This is global distress. Down here we have things like assertive anger. I've used that just to kind of help a little bit. And for the purpose of illustrating the graph, I've flipped it, right? So now down here is global distress, and up here is more productive emotion. You with me? Okay. So what I'm showing you is a graph that shows tracking emotion moment by moment. This is a single session, and we're coding every minute in a productive session, So this is a typical, if you've worked in therapy or if you've just worked through a difficult thing in your life, there are these kinds of ups and downs, right? These micro regressions or collapses that don't necessarily detract from an overall improvement. But I'm interested in those micro collapses, and you can see these are kind of moments of improvement in green, and then these kind of red lines will be these moments of suffering, right? And what this is sort of showing, it's not that people just continually get better, right? Right here near the end of session, the person is actually having a moment of global distress. But what we have here is a shrinking duration, right? The periods of distress, the time people spend in a collapsing state, right, start to get smaller and smaller. And the periods of improvement also seem to be, I think this speaks to what healthy emotional change actually is. When we look across clients, that was sort of a typical example from here. But if I take 17 clients doing that and I overlap them all over, you end up with a big mess. We could be looking for what's kind of the regression line here. And what we find, comparing poor outcomes to good outcomes, is obviously there's a steady advancement that's significantly larger for good outcomes. You with me? Now, a new idea. Well, that's a new idea. But if we're talking about what a healthy emotional change is, I would suggest to you it's not only that people have this steady improvement, right? And not only that people have this steady improvement, but actually that people become more flexible, that as you move forward, you have a broader emotional range. So that's an interesting thing to study because there aren't easy tests for that, right? But what we're talking about is heteroscedasticity, right? That over time, the variance is not equal. That over time, especially in a good outcome, the variance actually increases, right? You can imagine people having a steady improvement, give or take a certain amount. And my point here is that give or take actually widens and widens and widens with this steady advancement, because emotional flexibility is part of the healthy change, right? And I think healthy people have an experience of, well, I don't always feel fantastic. But when I feel terrible, when I enter a state of maladaptive fear or shame, first of all, I have other states to go to. And second of all, I spend less time in this maladaptive state, that I'm more resilient, right? So resilience, I'm going to suggest to you, isn't just that people have more productive emotion, it's that they bounce back more quickly. The bounciness changes, right? This is single sessions. If we look across sessions, this is a single case example. And now I'm just looking at presence or absence, which seems to have been a good kind of thin slice. Did they have that experience or not? So you can think of this as like a layer cake, right? These are the sessions, these are states, organized the same way. In session 3, this client experiences global distress, shame, fear, dread, and rejecting anger. 3 layers to that cake, so to speak, a presence of these 3 different things. But as they move through therapy, session 9, and eventually, right, we have this kind of advancement of, it's like this is the increase in emotional range. Not within a session, but now across treatment, people start to have a wider range of the emotions they experience. Sometimes one wants to look at this, but with this level of detail. That would takes a lot of time, but we did that. Because it allows one to look for patterns statistically, right? This is kind of a more rough and ready illustration, I think. But if we could also, if you think here, this is
every moment of aroused emotion in every session of an entire treatment, right? And we did this a couple of times. I'm showing you one case. So this is session 1. This is a little bit later in session 1. This is session 2, a little bit later in session 2, 3, 4, 5, 6, right? A 14-session treatment. No emotion in session 14. They're just wrapping up. And what we find here is actually, interestingly, if I sort of summarize this, you can use hierarchical linear modeling to look for patterns not only within sessions, but across the treatments. And it's across treatments that I'm most interested in this particular analysis. And what we find is this client building resilience, one step at a time. So the trend between therapy sessions shows this gradual increase in intercept, right? It's hard to see here, but you know, the intercept is actually changing, and it's this gradual advancement. So the client changes his presentation at each moment, at each emotional event as therapy progresses, and the positive changes were found across events in therapy. You might also ask, and then we're moving to kind of more specific, does it look similar in other treatments, right? I mean, that's a fair question. Some of the detailed analyses have been looked at. I've talked about different treatments, but focus on emotion-focused therapy. And so I remind you, you know, it has been studied in psychodynamic treatment. We have this study, another study on behavioral treatments, also done here at in the Department of Psychiatry. And then finally, general psychiatric management is another example where this is observable in here and is consistent with the model. And finally, you know, this is attachment-based family therapy, which is, again, a very different treatment, showing consistent, this study was actually showing consistent conditional links between emotions and directional predictions. This emotion before that emotion predicts outcome. So we're finding supporting evidence from different treatment approaches. And now we get to kind of the last piece, which is really, what do we know about intervention? It's one thing, something that keeps me up at night as a process researcher is, you know, one can spend a lot of research, process research, is observing what kind of changes happen in therapy that predict outcome, right? Well, when this happens, it predicts outcome. Great. When that happens, when clients are like this, it predicts outcome. The assumption that's underlying all that body of research is that if we know what happens in session that predicts outcome, we can make more of that happen. That's an assumption, right? Because one thing is tracking process that predicts outcome, and a different question is, can you facilitate that process? Right? I mean, it would be good to know how therapy works, but it would be even better to have findings that let us actually make more of that process happen, right? So this becomes a different question. This issue of therapist interventions, I think we've moved, hopefully, from the idea that somehow I will have a treatment and I'll just predict, you know, the treatment predicts outcome. There's lots of treatment outcome research, that's great. But you don't really know what's happening in the client. So you don't know the way by which that treatment works. To do that, you have to study what happens in session. So I'm suggesting a strategy, a research strategy here. Client emotion, I'm saying emotion because that's what we're talking about today. Client emotion predicting outcome is what we have been talking about. And so the next step would be to go moving backwards. What kind of therapist interventions, I'm not interested in them necessarily predicting outcome, what kind of therapist interventions predict clients having these emotions, which we know predict outcome? You with me? So you create a chain. Again, this is kind of a way of creating a causal chain of how emotion works in therapy. So you could look at early phases of treatment and sort of a working phase. And one thing, this was a study done at the University of Windsor. We could look at productive client emotion. Again, this is sort of anger, this idea of grief, self-compassion. And just look at what's happening early in therapy that predicts that. The kind of processes that we examined were these two, therapeutic relationship and the client depth of experiencing. And, you know, I thought both would predict. But the therapeutic relationship came out as one of the strongest predictors of whether clients had productive emotion later on in therapy. And I think that speaks a little bit to not only using the relationship, but as we'll see, there are other things that are important, but the relationship is in some sense a prerequisite, right? People are not going to go there without feeling safe or without having somebody kind of facilitate them. Very specific interventions have medium to large effects in predicting subsequent productive emotional experiences. Okay? Medium to large effects. I'm showing you two studies here. In clarification-oriented psychotherapy for personality disorders, the therapist's empathic understanding and process directivity. This is the client not saying, let's talk about that content or this content, but guiding the way, the manner in which clients engage their content, right? And empathic understanding, which is consistent with the idea of relationship. And in emotion-focused therapy for depression, focusing on emotion, focusing on unmet needs. This study, by the way, has actually shown that, within the same session, if in the first 20 minutes therapists do these sorts of things, then in the 20 minutes that follow within the same session, clients engage in these other kind of emotional advancements. I think the message here in general is orienting clients to focus on emotion and what their underlying needs are as a way of moving them through the model. Obviously, a mediation analysis is an important way of kind of looking at whether therapist interventions, how therapist interventions are relating to in-session outcomes. So this is a session outcome, a productive session that ends in deeper client experiencing. We know this is true. The question is why, or if we can explain why using more detail. So within a session, and what we decide to look at is just in terms of emotion, the proportion of these productive emotions. And we find actually there's an 86% mediation, right? Deepening client experience is probably the most studied in-session process that predicts treatment outcome and relates to, has been shown across treatment approaches. And what this study is suggesting is that when therapists focus on deeper experiencing, it's actually because it's mediated by the proportion of productive emotions. So productive emotion actually is the window. You don't deepen experience any old time. There's certain times when it's most important. Client engages certain emotion, now's the time to, in some sense, the model might say, where's the map, the lay of the land? How do you know where to navigate? And depth of experiencing is, well, when do you start digging more deeply? This is again a study done here. We find emotion mediates the impact of treatment. Here, it mediates the impact of an intervention. Here, it mediates the impact of the treatment. So people either in dialectical behavioral skills therapy training or in treatment as usual, 20-session treatment, and we see it improves functioning. And the mediator is increases in assertive anger. Increases in anger. It's a bit counterintuitive, okay, for a behavioral therapy. But what we find is a mediation, again. So mobilizing productive emotion is actually a mechanism of these treatment effects. Notice we're talking about increasing assertive anger and not actually decreasing anger problems, which is often a target in dialectical behavior therapy. So that counterintuitiveness of, with respect to the mechanisms by which behavior therapy or dialectical behavior therapy understands itself or is understood, I think raises some, for some people, it's kind of a question of methodological problems and so on and so forth. So we were delighted when there was a review in the Journal of Mental Health that reviewed all the existing research on change mechanisms in DBT and CBT and actually ranked this study as number 2 in terms of best methodological quality of all the studies published to date. So that was quite reassuring, right? And despite this being kind of a counterintuitive finding with respect to DBT therapy, or theory, I should say, it seems to hold and to be regarded as useful. I'll wrap up quickly talking about implications for clinical practice. You know, in some sense, you know, does feeling bad lead to feeling good? This model would say yes, it does, right? This is a figure from a different study, but the idea is illustrative in terms of experience, right? The arousing difficult emotion within a session, and within a session, you know, people feel worse at the end of the session, but actually there's an overarching gradual decline across sessions. So the repeated engagement leads to in a self-directed manner. I talked about, you know, the model maybe as alluding to kind of a map, a process map. Well, that could be a tool for psychotherapists, right? As one talks about what specific kind of emotion, the way one perceives client emotion is important. I think one of the contributions here is that sadness isn't just sadness, it's what kind of sadness? Anger isn't, you know, a study on is anger helpful in therapy? The question should be, what kind of anger, right? And as one is sensitized to that, it actually changes the way one perceives emotion, right? If you have two kinds of emotion in mind, then when clients get angry, it changes what you perceive. This is more productive or less productive. In terms of not only reading the lay of the land, so to speak, or the landscape of the client experience, it helps, I think, therapists having a map like this target what has been identified as emotional difficulties. You know, you can look at a process map like this, or rather look at a client through the process map as a lens and kind of say, here's where the client gets stuck, or there's where the client has, it always collapses, right? And then adjust clinical interventions accordingly. So in some sense, this could be a template for case conceptualization. Here's a case, but the punchline is this sort of idea, right? I'm just trying to illustrate, here's the model, obviously, and the client's doing a lot of this. The client gets stuck here and has these core sort of negative self-evaluations, right? It's, oh, this is what, you know, I mean, it filters through. I'm trying to illustrate visually a little bit the idea that the therapist who's working with this client can perceive client experiences differently and map it use the model as a map. The implication is also where to focus treatment. That addressing a need is going to could come out of this experience, actually. The emergence of a need can come out of a maladaptive experience. And that assertion or self-compassion will be important parts of the resolution process. Obviously, case conceptualization will have many more details, but I'm trying to give you a snapshot, really. And so we're helping this client transform maladaptive shame to adaptive anger or self-compassion. That becomes a treatment goal. So emotion sequences can be defined in concrete and clinically relevant way. That's pretty important. It's not just an ongoing flow of emotional stuff, right? I mean, I think we can isolate the kinds of emotion. It's not exhaustive. Obviously, people feel lots of things. The model is only interested in the kind of things that lead on a pathway toward improvement. And that research supports a specific model, right, of emotion changing emotion. Predicting session change, predicting final symptom outcome. The other thing is that therapists can use a priori knowledge of this model as a process map, which is what I was describing. But there's this trick, right? As we've seen, you can't just jump to the ending. You can't randomly assign clients to experience positive things. You have this moment-by-moment facilitative process. Actually has to come bottom up. You have to work with what the client has. And I think that's quite key. So finally, last slide, this idea of emotion changing emotion. What I hope to have shown you today is the modeling of a mechanism of emotional change, right? And capturing what may be a universal principle of adult emotional development, that this is a pattern of change that predicts outcome, leads to healthy change, and seems to be found across treatments that have been studied so far and across disorders that have been studied so far. So I think there is where we will end off. Thank you very much.
you very much, Antonio Pascual-Leone. En fait, nous n'avons pas prévu des questions, donc tout ce qui me reste à dire, c'est de vous remercier de tout cœur d'être venu. Et une très belle journée à tous, et j'espère que ça vous inspirera dans la recherche et aussi dans la clinique. Je suis sûr pour moi-même. Merci beaucoup.